Okay. So welcome to our last class of the semester. Today we'll wrap up the semester with audiology and hearing loss. But before we get into that, just a few announcements that I want to make, and I will put all of this also into an announcement that I'll email and put on Canvas for you, so don't panic if you don't get all of this. But first things are, I'm going to ask you for a deadline to turn in all of your homework by the 18th of December. So today we are the 8th. So basically in 10 days time, I really need to get everything in from you. Next week is our finals week. And you've got one more piece of homework after today. So today or yesterday you turned in hopefully your homework number 9. That was your dysphagia. And then you'll have one more homework left, which is audiology and hearing loss. And so typically, you know, you get, you turn that in. I'm just looking at my calendar here so that I can make sure I get my dates right. So that will be due, your audiology and hearing loss homework will be due on the 14th. That's next Monday. And you will have until the 18th to turn it in. But I really have to give you that deadline of turning everything in by Friday the 18th. That is partially because I just need to make sure that I have time to grade everything, and I really look through your tests, your homework. The 19th is my day, then the Saturday, that I'm going to go crazy and go through all of your grades and everything. So I want to make sure that I have that day to do it, because I'm working in the hospital on the 20th. And then from the 21st, I have potentially jury duty. If I get called for jury duty, game over. So I really have to make sure that I have got all of your grades and everything in before the deadline for which I have to submit it. So that's my request to you, is everything's got to come in by the 18th, please, anything that is outstanding. So our final test, I'm going to make that available to you starting this Saturday, which is the 12th, all the way through until the 18th. So you will have all of next week pretty much then from Saturday. So I wanted to make sure that you all have a weekend. If weekends work best for you, then get that done this coming weekend. If you need the time or you don't have to do it at the weekend, you can do it anytime next week, and you'll have up until, again, Friday the 18th to turn it in. It's going to be same as the other tests, 75 points. You'll have 90 minutes to do it. You obviously open note test, so make sure that you still have studied beforehand, because you don't want to run out of time just because you're trying to find information. I've got office hours today from 6 to 7. So if you have any questions about your grade or any concerns, you can come and see me today. On Thursday, the office hour between 4 to 5, that's where we have our ASL interpreter coming. So I invited somebody from OSD who interprets for the students at Cal State LA to come and talk to you about maybe what you can do with ASL, because I know lots of you take lots of ASL classes and might want to, how do I work that into a job somehow, or what kind of jobs are out there. So hopefully she'll talk to us a little bit about that. If you cannot attend the office meeting on Thursday, I will record it and I will post it. If you have a question to ask or you have a comment to make, I will give you extra credit points either in person or afterwards if you watch it, to help you get a few extra points before the end of the semester. And then I will actually have my very last office hour next Tuesday, the 16th, from 6 to 7. So if you can't make it today or Thursday, but you still want to come and talk to me, then next Tuesday, which will be the 16th, between 6 and 7, I'll have my last office hour and you can come and let me know what's going on. Please, between now and the end of the semester, please check that you have grades for everything that you think you have submitted. And as I said last time, I know that this semester has been really challenging for everybody, but it's been more challenging for some of us than others. And some people have had COVID in our class. Some people's families have had COVID. Some people have lost a job. Some people are trying to struggle to manage their job. and taking all your classes. So I know it's been really stressful for a lot of people. So if there's homework that you have outstanding, even if it is from early on in the semester, just email me, and I will I'll arrange a time to either meet with you or we'll figure something out. So a couple of questions. What chapters does the final cover? Let's pull up. So the three sections that will be in the final will be motor speech disorders, dysphagia, and audiology and hearing loss. So I believe, if memory serves me right, correct me if I'm wrong, that should be chapters, I think, 10, 11, and 12. I'll have to look at my study guide. I will post a study guide for you. Basically, when you're trying to study, I would say the best thing to do is to, if you haven't attended the class, watch the recording of the class, really go through those PowerPoints, check that, you know, when I've graded your homework as well, I always put comments on your homework if you made some errors. So go through and check your homework and check the comments that I've made, because their information for the homework is really important for the test as well. Do the reading that corresponds to those three modules. I think to make sure that you understand the concepts, to deepen your understanding, to make sure that it all fits in. But I would say, if you are strapped for time and you feel like, I don't have a whole lot of time to do all the reading, read through those chapters if you can fairly quickly, but don't spend time like taking notes on all the chapters and then find you run out of time and you really haven't looked carefully at the PowerPoints and the homework. So I would say, you know, everybody works a little bit differently, but reading the chapters, I think, is good to just sit and read, help it to sink in, review it, but you don't necessarily want to spend ages taking a whole bunch of notes from those chapters. So I hope that's helpful. And write a little note to myself to remind myself to put the study guide on. And then based on what we get done today, I will fix up, or let me share my screen with you for a moment. Let's see. This is what we look like for week 15. So here's your last homework, chapter 12, and the pages are there for you. We've got and this is posted on Canvas for you under week 15. So you've got all that information that I just talked about. Then you've got the information here about the final exam that is also up there for you under week 15 as well, just to make sure that you have it. And I will put up a study guide for you. So this TBD, to be decided. Let's see how we get on today, how much we cover, and then I will put on there for you what the rest of your week will look like for your self-paced studying for audiology and hearing loss. Okay. Before I jump into, the slides, thoughts, questions, did I miss anything? Crossword puzzles. Yeah, I think I do. Maybe I owe you a crossword puzzle as well. So yes, I will make sure I've posted those or made them. They're in there, but I don't always make them visible until we're ready. So yes, I will make those crossword puzzles visible to you too. All right, dive into the last topic, audiology and hearing loss. Now, I don't know if if anyone here is interested in audiology. Type in the chat box if you think you might be an audiologist. You know that in order to be an audiologist now, you have to get a doctorate. So we have a doctorate program at Cal State LA, and that's been going, I think maybe this is either the first or the second year. It's pretty new that there has been this doctoral program. So we have some great audiology teachers. So if that interests anyone, you can think about that. And then anyone who came to the little presentation that Phil did, and that's also posted, you can have a little listen to some of the questions that he answered there. All right, let us, get my slides up. Okay, here we go. Let me make sure I've got my chat box open so that I can see everything. Okay. Audiology and hearing loss. So when we're talking about audiology, you know, and we think about, you know, who the people are that are audiologists and what their job is. Their job is not only to be evaluating somebody's hearing and to be prescribing perhaps hearing aids or cochlear implants, but they are also involved in trying to prevent hearing loss. They do a lot of education to prevent hearing loss. And in fact, that's what Phil, that's the purpose of his presentation, was to tell us all off for using our earbuds and listening to loud music. So they really do try and prevent hearing loss, especially in young people who can get noise-induced hearing loss, and we'll be talking about that today. So they also work on rehabilitating people who have had hearing loss, and we will talk about that later on. But I think maybe what we will start off is, let's watch just a 1.5-minute video to get an overview of hearing, and then we will pull it apart and we'll talk about all the pieces. We'll be looking at the anatomy and physiology related to hearing. We'll be looking at disorders of hearing, and maybe evaluation if we can squeeze some of that in as well. But let's start at least with watching this first video. Oh, sorry, let me make sure I've also got my proper...
Sound waves entering the ear travel through the external auditory canal before striking the eardrum and causing it to vibrate. The eardrum is connected to the malleus, one of 3 small bones of the middle ear. Also called the hammer, it transmits sound vibrations to the incus, which passes them to the stapes. The stapes pushes in and out against the structure called the oval window. This action is passed on to the cochlea, a fluid-filled snail-like structure that contains the organ of Corti, the organ for hearing. It consists of tiny hair cells that line the cochlea. These cells translate vibrations into electrical impulses that are carried to the brain by sensory nerves. In this cut view, you can see the organ of Corti with its 4 rows of hair cells. There is an inner row on the left and 3 outer rows on the right. Let's watch this process in action. First, the stapes rocks against the oval window. This transmits waves of sound through the cochlear fluid, sending the organ of Corti into motion. Fibers near the upper end of the cochlea resonate to lower frequency sound. Those near the oval window respond to higher frequencies.
Okay, so that was just a quick overview, so that as we talk about hearing and hearing loss, you've got a little framework now to work from. And there's another video that I will set you to look at over the next week that really repeats that with a little bit more detail, but at least we get an idea of all the pieces in there. So before we get into the anatomy part of it, let's first of all talk a little bit about sound and how sound moves. So we have the source of sound. So for example, right now, the sound source is my voice. And as I speak, my voice sends these vibrations out. And it's a little different because we're not in person. But if we could imagine that we were in person, what would be happening is that as we were in person, as I speak, the air particles move because they transmit the sound source through air particle movement. And the air particles vibrate, and these vibrations move from molecule to molecule. So basically, as I'm speaking and the air particles are moving around where I speak, these air particles themselves don't move all the way to your ears if you were sitting in the room with me. They transmit the sound from one air particle to another until those air particles that are close to your ears start to be heard. Now, as these air particles move, we think about the distance that they travel. And air particles that travel a longer distance are because they have an increased amplitude. Amplitude is what we refer to when we talk about loudness. So if I speak really loudly, those air particles are going to travel a greater distance. If I speak really softly, then the air particles will travel a shorter distance. And hopefully that makes sense, because you can imagine with that increase in pressure, that increase in my voice, it's going to send those air particles a greater distance. And so therefore you will perceive it in your ears as, wow, she's shouting. But if I'm speaking very quietly, obviously the air particles are going to be moved just a smaller distance. So when we're talking about amplitude and how loud a sound is, it refers to the distance that those air molecules are moving. When we're talking about frequency, and we talked about frequency when we were studying voice, we know that frequency refers to pitch, what we perceive as pitch, and that refers to the number of cycles per second. So when we're thinking about sound, we think about these molecules that are moving. They are doing a back and forth movement. So sounds that have a higher frequency or a higher pitch are going to move back and forth more frequently. So that's the perception of a high-pitched voice. Sounds that are a lower pitch, whether it's voice or just a lower pitch sound, are going to be moving back and forth more slowly, fewer cycles per second. So we want to make that distinction again between amplitude and frequency. Amplitude refers to loudness and how far those molecules move. Frequency refers to pitch and how quickly those molecules move, the cycles per second, and that's what we hear as high and low pitch. So hopefully that's a little bit of a repetition, because we talked about this in voice, and maybe if you're taking any type of an audiology or acoustics class, that may fit in with what you're learning as well. But we just want to know that when we're talking about how we process sound, we first of all do just have to know how sound moves. Okay, so now we get into so we've got these molecules that have moved, and the vibration, that sound source has arrived at the ear. What is going to happen to it? So we divide the ear into three parts: the outer, the middle, and the inner ear. So we're going to take a look at the anatomy of each one. And in fact, if I jump forward here, this is what we're going to be looking at. And you will see we've got the outer ear, the middle ear, and the inner ear. So we'll hop back and forth between this slide with those terms on it and then the actual diagram. So when we start at the outer ear, think about your pinna. The pinna is the big part of the ear, the external part that we typically think of when somebody says ear. This is what we are thinking about. When you think about dogs' ears, I know that one of my dogs she has these giant kind of batty ears. And even when she's sleeping, these giant batty ears are just ready for sound. And if you ever look in a dog's ear, you will see that they have all these weird kind of convolutions, because their ears are really set up for channeling that sound. That's why they can hear you. My dogs can hear my car down the street. So by the time I actually stop outside my house, they are already at the window barking like crazy, because you know their ears are so attuned. Now humans, our ears are still designed to gather sound and to send it down to our ear canal, but not quite as sophisticated as a dog's ear. So we have that pinna, that external part. We also have the ear canal, the external auditory meatus. So here is our ear canal right here. You know, that's when you put a cotton bud in there, which you shouldn't do, by the way. But if you clean your ears with a cotton bud, you should be careful. You should know that our ear canal is only about 2.5 centimeters. So any of you who know metric, you know, that's about just over an inch. If you don't, think about, that's quite small. So you should never be putting a Q-tip all the way in, because your ear canal is only about 2.5 centimeters long from here to here. So this is the outer ear. So as we are getting, remember we just talked about these air molecules, that the vibrations that we have got from my voice speaking, they're going to enter via the pinna into your ear canal. And at this point, the sound is acoustic energy. And you are going to see that as we talk about this, the energy type changes because of the medium in which the energy is moving. So at this point, you know, it's moving through the air into our ear canal. It is acoustic energy. Now we're going to get to the middle ear. And the middle ear comprises the tympanic membrane, the ossicles, the eustachian tube. So let's talk about those things. So tympanic membrane, here is that little tympanic membrane. That is what we typically call the eardrum. So your eardrum is this very fine piece of, it's like a little kind of muscle and tissue that responds to this acoustic energy. And it is going to transmit that acoustic energy all the way through this chain of little bones. Now, maybe what I do want to do quickly is just to share a picture. If anyone has ever had their ears looked at and you've ever been able to see your eardrum, it is absolutely fascinating, I have to say. Let's share this with you. So this is what it looks like. That's what the eardrum looks like. This is a beautiful eardrum. You should enjoy this now because we're going to see some nasty ones later. So it should be clear like this. It looks a little kind of pearly. And what to me is absolutely fascinating is you can see those tiny little bones through there. So if you think about that sound source, that, you know, my voice that is moving those air particles, it is going to be bouncing on the tympanic membrane or the eardrum. And that eardrum is then going to transmit that energy to those little bones. Now, if you want to see a less beautiful eardrum, oh no, maybe I'll save that. Okay, let's keep for the beautiful one for now. Okay, so that's our eardrum. Whoopsie. Let's go back to my slides. Okay, so we've got this tympanic membrane, and it's going to transmit that information, then that sound information through this little chain, the malleus, the incus, and the stapes. And so you can see, and we saw it in that little video, the malleus is the first one, the incus, and the stapes. And so they act like a chain, and they transmit, one bone transmits information to the next and to the next. What is important to remember about this stapes is the stapes looks a little bit like a stirrup. That's the other word for it, is the stirrup. And it's the bottom part has a foot plate on it. And this foot plate is very important because this foot plate is then what transmits the information into the inner ear. It is located at this anatomical part here that is called the oval window. So the oval window is a membrane, and this stapes foot plate meets the oval window and is going to push the sound source is going to continue. Now at this point, the energy you'll see has changed, and the energy is now mechanical energy. And if you think about that, the bones work like a piston. So they push that energy, it's very mechanical. So we've changed from this acoustic energy as that sound reached our outer ear to this mechanical energy, those bones pushing the sound on. So that stapes foot plate is very important as it butts up against the oval window, because that is going to transmit that mechanical energy through this little membrane into the inner ear. Now we've got this other structure here called the eustachian tube. So let's just take a quick side step for that. The eustachian tube, it is this little tube that basically ventilates the middle ear space. So the main function of it is to make sure that we have even air pressure, normal air pressure. So you will know if you've ever been up high up in the mountains, you've driven up there, there's a point at which your ears start to feel blocked and funny. That's because your eustachian tubes are trying to, you're trying to normalize that air pressure. because you think it's an open tube. So as the air pressure changes outside, it affects how we hear, because the eustachian tube is trying to help us to normalize that air pressure. If you've ever been in an airplane, you'll know that there's a point sometimes where it feels like your ears pop. Some people have very painful ears when they fly. Babies often get painful ears when they fly. And it is because we have difficulty with that change in air pressure. Secondary function is that it is to drain any secretions that we have, any infections that we have from the middle ear space. So we'll be talking about that in a minute, but think about that middle ear space from the tympanic membrane through those little bones. We can have a lot of issues there, and children do in particular. Now, one thing that is interesting, just a little side note, is you will see that in children, that eustachian tube is fairly kind of flat looking, and as we get older, it becomes more at an angle. What that plays into is the fact that children get a whole lot more ear infections. They get a lot more blocked up than we do. As we get older, think about gravity helps us, because if we get an infection, if we get any fluid, gravity is going to help that to drain. But for children, when you've got that eustachian tube that is very flat, it often just stays in there. And we'll be talking about ear infections in a little bit. So this is also then part of a middle ear structure that really is to do with ventilation and draining of any fluids. Okay, and you will see here it is, the eustachian tube right around there. Okay, let's go to the inner ear. Okay, so now when we talk about the inner ear, we're going to be talking about the oval window, the cochlea, the semicircular canals, and then we'll talk about how the energy changes. So we already talked about that oval window and how the stapes footplate is passing on that energy. Let's get to the cochlea now. As we saw in that little video, the cochlea is this tiny little structure. It is crazy. It is the size of a pea. It is this teeny weeny little structure that is curled up a bit like a snail shell. So if you think about how tiny that is, you know, it's this really small structure. And now we're going to be talking about structures within the cochlea. So you can imagine all of these structures within the cochlea are absolutely tiny. Let's take a quick look at the cochlea in a little bit more detail. So if we were to unravel the cochlea, like you saw in that video, we were to uncoil it because it's difficult to see, we would see that we have these different areas or labyrinths within the cochlea, and we have spaces, and these spaces are filled with fluid. And so the fluid has a number of different functions. One of the functions is to help us with balance, but it's also to help transmit the energy, the sound source. Fairly near the center inside the cochlea is this structure called the organ of Corti. Now, you will learn a whole lot about this in your audiology class. But what we want to know about the organ of Corti is that it's this complex structure where we have these hair cells that are called cilia. And these hair cells basically respond to sound. And the hair cells are organized that different hair cells will respond to different frequencies of noise. And we just talked about frequencies referring to pitch. So as you hear a different pitch in your ear, and remember it's being transmitted through the acoustic energy, the mechanical energy, and now it's into the cochlea, the hair cells respond to different frequencies. They are then going to send that information, as those cilia respond, they will send that information through to the auditory nerve, which will then go into our brain and we will process it. We don't need to know about this in too much detail, but what you do want to know is that the cochlea is a tiny structure, that when we unravel it, we have these open areas, these labyrinths that are full of liquid, and that we have these little hair cells that respond to frequencies. Now, interestingly, I don't know if you caught a little bit in that video, it is organized from highest pitch to lowest pitch. So the highest frequency sounds, the cilia that respond to that are basically first in the organ of Corti within the cochlea. That is not surprising then, that when people lose hearing, they often lose high frequency sounds. And think that is partly because of just where they are located. So as we get older, we tend to lose some of those higher pitch sounds. Okay, so you don't need to know the difference between perilymph and endolymph. Just know that that is the liquid that is inside of the cochlea, and know that we have the organ of Corti, and then within that those cilia. And if we just take a little look again, we're talking about within the cochlea, and then if we were to cut it, and we would see the cilia within the organ of Corti. Now we also want to maybe talk a little bit about the semicircular canals. And the semicircular canals are also filled with fluid, and they do a very good job of helping you balance and of you knowing where your body is in space. As you move, if you move your head quickly, you move up and down, the fluid in there helps to let your body know where you are. This is so that we don't get dizzy when we move our heads side to side. I am convinced that as we get older, it doesn't work very well, because I know that when I was a kid, oh my God, I loved going on all the rides at the theme parks. And now I get so dizzy. I can't even go on a swing without getting dizzy. So enjoy it while you can, people, because you may not have such good semicircular canals as you get older. So the purpose is to help us with balance and to know kind of spatially where we are. I think that's all I want to say about that. Let's go back. Okay, let's just talk now about the energy. Now the sound has been translated into neuroelectric energy, because those little cilia that have been activated with the different frequencies send an electrical impulse that goes down the, here's the nerve here, it's cranial nerve number 8, the acoustic nerve also called the vestibulocochlear nerve, and that carries that impulse to the brain, and then we figure out what it is that we're hearing, and we can localize, we can see, you know, where it is, we can figure out what it is. There is another video here, that's the one that I was just talking to you about, that you can watch at home, that basically just gives you another run through of this. And I like this one because it's in a little bit more detail, but it's only about 3.5 minutes. So, man, in a nutshell, that's really kind of how we process sound and how it changes from the outer to the middle to the inner ear. Okay, let me just make sure that I've got my chat box open. Whew. Take a little sip of water, everyone. Enjoy our swallowing muscles that we learned about last time. Any questions before I dive into the next part? I think if you watch the video as well, that will just help cement that. Okay, so let's talk about hearing impairments. Now, there are 2 main types of hearing impairments: conductive hearing impairments and sensory neural hearing impairments. A conductive hearing impairment is where we have got some type of damage or injury or disorder in the outer or the middle ear. So just to think about, conductive hearing loss is going to occur from the pinna all the way basically to the stapes foot plate. So anywhere in this part here is where we would have a conductive hearing loss. And a sensory neural hearing loss is related to the inner ear. So really we're talking about the cochlea or something happening in the auditory nerve. Of course, we can have what is known as a mixed hearing loss, and that is where somebody has got an impairment in the outer or middle ear and the inner ear. So you can have both of those going on. So let's talk a little bit then about conductive hearing loss. Now, when we're talking about conductive, let's talk about, first of all, the ones related to the outer ear, and then we'll talk about ones related to the middle ear. So in the outer ear, what could go wrong in the outer ear? Well, we have something that is called microtia and atresia. And let's skip to the next slide so we can even take a look at that. Microtia is where somebody has a small or malformed pinna. And you can see from the picture here that it is graded according to severity and according to how much of a change we see. Now, this occurs during embryonic development. So this is while the baby is in utero, and during the embryonic development, we have some abnormal development. So grade 1, you can see, is just a bit smaller, but mostly looks normal. Grade 2, part of the ear looks normal, usually the lower half. Now, atresia refers to blocking of the ear canal. So microtia refers to the ear, the pinna, and atresia refers to a blockage of the ear canal. So the canal can be small or completely closed. Once we get to a grade 3, we just see a very small amount of pinna, and there is no canal, which is called oral atresia. So there is absolutely no canal there. So sound obviously is not going to be able to get in very well, right? Because there is no ear canal. And then grade 4, there's a complete absence of both. And you can see there that where perhaps we would have had an ear canal and an ear, there is no ear canal, there is no ear. And that is called anotia, which is a complete lack of ear canal. Now you'll see down here, there is really good surgery. And you can see here it is before. Here's this little guy before he has surgery, and here it is afterwards. So you can have very good results. Now you can imagine when somebody has a conductive hearing loss like this, the sound can't get in. So if we can make the sound loud enough, the person can hear it and process it. Maybe a little side note on what I should have said before is that when we think about conductive hearing loss, all of these types of hearing loss, the sound is prevented from getting to the inner ear. Most conductive hearing loss is temporary. It can be fixed or medically treatable, I should say, as well. If we can make the sound loud enough as well, typically children who have these issues can hear well enough. Okay, so we talked about microtia and atresia. Secondly, earwax, number 2, impacted cerumen. This is, sorry if anyone has just had lunch or was going to just have lunch, but this is what it can look like when people have a bunch of earwax that get stuck in there. Now, this can happen to children, it can happen to adults. Some people just produce more earwax than others. And, you know, earwax is there to help keep your ear sterile. It is there to help not get any foreign objects in there. It is, you know, it's really there to help us. But what can happen is that if people get large amounts of earwax and they're not able to clean it out, is that it can get impacted or stuck in there. And then the last one is a foreign object. Now, at this point, I might have to just have faces on here. This is your opportunity to confess to anything you ever put down your ear as a kid. Now, I can start the ball rolling if you like with a couple of stories that I had from previous classes that I think were absolutely hilarious. There was one student in class, I think it was maybe just last semester, when she was little, she put a bean in her ear, and her parents didn't know she had put a bean in her ear, and the bean started to grow. So she had a little bean growing in her ear because you think your ear is moist. And anyway, so she's now a grown woman with children of her own, and she told our class that to this day she cannot have beans in her house. She doesn't cook beans, and she said, and this is really bad because I'm Latina and I cannot have beans in my house because it's just, I think she's just got PTSD from this bean. So that was one. Other good stories, we had somebody who was a nanny, and the kid that she had worked for, when she was not watching, he had put his hand into the aquarium and he'd taken lots of those little coloured stones and put a whole bunch of those aquarium stones into his ear. Feel free, anyone at any point, to unmute, and if you can top any of these, I would love to hear it, because I have a whole catalogue now of things people have put in their ears. If you're too embarrassed to say it and you want to just put it into the chat box, if you put it privately to me, I will not disclose your name. I will just read it to the class.
I have a story, actually.
Oh, good.
So, so when I was little, my cousins and I had a corn kernel fight, and we were throwing popcorn kernels at each other, and one landed in my cousin's ear, and we had to go to the doctor and have it removed. Yeah.
Because the problem, Brenda, is you can't, like, you're going to push it in further, aren't you? If you try and get it out,
Yeah.
and especially corn cones, you think how kind of they're hard and slippery.
Mm-hmm.
Who would have thought you could have had such a good shot to get it
Yeah.
right in there? That's a good story. I'm going to add that to my library. Thank you. Anyone else got a good? Okay, I've got another one. Oh, here's another one of my favorites. One of my students said when they were little, they put pop rocks in their ears so they could hear really well what they sounded like. I love that one. Somebody else said, you know, those cute little pom-poms that you get to decorate, you know, those little, she had some little pink pom-poms and they were so pretty and so sweet that she just popped them in her ear. I think maybe she just wanted their ears to be happy, who knows. But so the moral of the story is don't put anything in your ears because they are really difficult to get out, and you may have to go to the ER or urgent care to get them pulled out, because you have to be really careful that you don't, I mean, we just saw the tympanic membrane, right? Delicate. You would not want to be poking anything to try and get something out. So yeah, we have to be very careful about that little membrane. If at any point later on you feel that need to confess, you know, shoot me an email and I will just add that to the stories. Okay. Okay, so that's our outer ear issues. Now let's talk about middle ear. So we're still talking conductive, but now we're talking about the middle ear. So we're going to talk a little bit about otosclerosis, otitis media with effusion, and PE tubes. So let's start with this one. So remember, we're talking about the middle ear, which is then the tympanic membrane and the ossicles. When somebody has otosclerosis, they have got something that is a genetic disorder where the healthy bone, think about, you know, we're talking about these little bones, the healthy bone gets replaced with spongy bone. And remember we said that it's mechanical energy. You know, those little bones have got a piston against each other. It's particularly challenging if that the stapes, that last bone in the chain, and the foot plate, if that has become spongy, obviously, instead of being a nice hard bone that is going to push against that tympanic membrane, if it's become spongy, it's not going to be able to push against, against the oval window, not the tympanic membrane. It's not going to be able to push against that oval window. So sometimes what happens is that somebody will actually have a surgery and they will put on a prosthetic stapes foot plate. So if we just briefly go back again to, I hope this is not annoying, but just so that we remember. Here's the stapes. So if you think, if any of these bones, any or all of them have become spongy because of this genetic disorder, they are not going to work very well in that chain. And especially, you know, our problem is going to be here if that stapes foot plate. So this can be replaced with a prosthetic. Can you imagine how tiny that surgery is to put on a prosthetic foot plate? We're talking about these tiny bones. I think they must send fairies in there. Okay. Otitis media. Now, you will know otitis media as an ear infection. This is the most common cause of conductive hearing loss, ear infection. Interestingly, it is the most frequently diagnosed disorder in the US in children under the age of 15. So even up until the age of 15, this is the reason that children most frequently go to see their doctor, is because of ear infections. It tends to be the worst, I think, between about 6 months and 2-3 years of age. Children can be very prone to having ear infections. So otitis media on its own is really an inflammation. So if you look at this top picture here, you can see, ouch, that is an inflammation. That is your otitis media. So the ear becomes inflamed. What can cause this is that, remember we talked about the eustachian tube. If the eustachian tube gets blocked, it starts to cause this negative pressure. And so negative pressure means that the eardrum is being pulled internally. That hurts, you know, it's painful. That's why children complain, because they've got this negative pressure pulling on their eardrum, and the eardrum can become inflamed. What can also happen then is that buildup of fluid, if that child has got a buildup of fluid behind there, which is this picture right here, we can see that there is fluid behind the eardrum. that can also be very painful as well, because now it can be bulging and pushing on that eardrum. So that is our otitis media with effusion. Now, if you have a child who keeps getting ear infections, often they are treated with, sometimes with antihistamines to see if they've got any allergic reactions. It can be treated with antibiotics if it is infected. And if none of that works and you've still got a child who keeps getting ear infections, they put in these tubes here. That's what these pressure equalization tubes are, PE tubes. And basically there's a little slit that is made in the tympanic membrane. This little tube is put in to allow drainage of those fluids. So this is why, you know, when we talked about speech in children, and those children who perhaps are missing speech sounds, and we said you have to do a hearing screening, partly it's because, imagine if you've got a child who's got all these ear infections and they cannot hear speech sounds, they may not be producing speech sounds because they don't hear them properly. So we definitely check to see that this is not a child who has got recurrent ear infections, and some kids just seem to unfortunately keep getting them. These PE tubes usually stay in there, and eventually they will just fall out. Now you can imagine you wouldn't want to keep having these put in there, because every time you put those in there, you've got to make a little opening in the tympanic membrane, and that has got to heal up afterwards. All right, so that's our middle ear infection, otitis media. All right. Let's move on now to the sensorineural hearing loss. So now we know that this is associated with damage to the inner ear. When we're talking about sensorineural hearing loss, this is hearing loss that is typically permanent in nature. There is usually you know, we can ameliorate the hearing, but we cannot replace it often, especially if you see that, you know, it's caused by a syndrome, caused by a disease. Now, the difference here as well is that if we increase the volume of the sound source, when somebody has got a sensorineural hearing loss, it doesn't necessarily mean that they will be able to hear it clearly. Because when you think about how the cochlea has got all those little hair cells, if you've got damage or impairments in the cochlea, you can make that sound louder, but the person may still not be able to distinguish different sounds. You know, contrast that with conductive hearing loss. If you've got a kid who has got otitis media, and so their ear is blocked, if we make it loud enough, that child should be able to hear it. We just have to increase the volume, but that is not the case for sensorineural hearing loss. So let's talk a little bit about that. So could be caused by a syndrome, by diseases. You know, I'll throw a few syndromes out there, but you don't have to remember this. Usher's syndrome is one that includes a hearing loss component. Waardenburg's syndrome is another one. But there are many, many types of syndromes that do occur. Diseases, there's one called Meniere's disease. I know somebody who's got that, and that can cause a buildup of fluids. It can cause permanent hearing loss. Somebody can have vertigo with that as well. Other ones that are important to know about are meningitis. Now, I think we've talked about this before at some point. From your neuroanatomy class, if you've taken it, you will know that the brain has this layer covering it called the meninges. And people can get an infection in the meninges, an inflammation. And inflammation, that's what itis means, right? Anything with itis on the ends means inflammation. So inflammation of the meninges. This can be very scary, because some types of meningitis can potentially, you know, kill you. And I don't know if you remember, a few years ago, there was a breakout of some type of viral meningitis at, I think it was UCSB, and a bunch of students got meningitis. So some of it is viral, and you can catch meningitis. It's very dangerous in babies as well. But a lot of the time it is a bacterial infection, so it's not viral, although this one at UCSB, I believe, was a viral one. That's how people caught it. Now, what do we do when somebody's got meningitis? We have to give them medication to take care of that. And some of the medication that we give to somebody to help them recover from the meningitis actually causes hearing loss. So they are known as ototoxic drugs. So ototoxic drugs have as a side effect sometimes hearing loss. So you have somebody maybe who has meningitis and has already got, you know, a big problem. We treat it with these very strong drugs and they end up with a sensory neural hearing loss. Doesn't always happen, but if somebody needs a lot of the medication or they need it over a prolonged period, it can happen. All right, and then an acoustic neuroma. That is a tumor on the acoustic nerve. So you can imagine if that, we talked about that auditory nerve takes the signal to the brain for processing. If you have a tumor on that nerve and that tumor has to be removed, sometimes a person will get hearing loss on that side that is permanent because the nerve gets damaged. All right, here's a big one, noise-induced hearing loss. Okay, here's time for us to do a little, you can either unmute yourselves or you can go into the chat. Okay, noise-induced hearing loss. Blurt it out or type it into the chat box. What kinds of jobs do you think people do that would give them the worst exposure to noise and where they could suffer from a noise-induced hearing loss? Have a little think about it. Think about anybody that you know that works in a job that is very noisy. Good, I want to give you a moment, put something in there if you think, okay, what have we got so far? Construction. Absolutely. People who work in construction, right? We see people when we're driving and who are working with huge equipment, and think about those jackhammers. Even if you've got noise protecting headphones on, I mean, that can still be such a lot of noise exposure. People in the military, absolutely. If you are exposed to explosions, gunshots, absolutely. People who work on trains, yes. If you are, think about how noisy trains are, and think about it's the length of exposure as well. While we might say, well, we go on trains, well, we don't spend all day on a train every day, do we? Think about it's the length of time as well. Somebody who's a bartender, yes, if you work every night for 5-6 hours a night in a really noisy bar, that absolutely will damage your hearing. Factory, absolutely. Being in a factory can really damage your hearing. Somebody who works at a concert, yes. Think about if you are someone who is involved in lighting, sound production, even if you're somebody who is like in the concert taking tickets, absolutely. Security for concerts, yeah, excellent. Musicians, oh my goodness, if you know any musicians, you will probably know that yes, they have often hearing impairments because they are exposed to it for years. Somebody who works at a gun range, absolutely. Can you imagine hearing those shots going off all the time? People who are the luggage or baggage controllers, absolutely. Think about, yes, people who are out, if you've flown on a plane and you have seen those people who are also directing the planes, people are unloading the luggage, think about the noise from the planes. So these can all be causes for noise-induced hearing loss. That's the biggest type of hearing loss. I'm going to put myself into your age range, but in our age range, you know, that's mostly what we are going to have is noise-induced hearing loss, because we either work places that are really noisy or we have leisure time exposure to them. And over time, you know, we talked about those little cilia. So those little cilia that respond to different frequency sounds, if you keep doing the same job that has the same type of noise exposure, typically what happens, you know that if you've gone to a concert one night, by the time you get home, what happens to your hearing? You have ringing in your ears, right? That stays, and usually it's gone by the next day, but it is because those poor little cilia have been bashed down by that sound. And so as they get kind of bashed down by that sound, they are sending signals to your brain. That's why you hear that ringing in your ears, because they are sending the signal to your brain that there is noise. If you're young and healthy, they bounce back up again. But over time, they lose that ability to bounce back up. So over time, those same hair cells that keep getting bashed by the noise, they just don't respond. So you miss that frequency. You have a a hole in that hearing in that frequency. So just know about that. I remember my husband has generally very good hearing, and he was in graduate school. You know, he went through the program too. He just copies me. And he had his hearing tested, and he came back home and he said, they tested my hearing at Cal State LA today. And look, and I have this big notch here, and my hearing's really good. And then I looked at it and I said, noise-induced hearing loss. And he said, well, you know, where would I have got that from? His uncle had a machine shop, and he was on a machine grinding carbide for 8 hours a day. And carbide, you're in a massive factory, and then you're at a machine and you're just going, and you're just kind of drilling and grinding this stuff. And so he has a noise-induced hearing loss from that, and it's very specific. So we often see it in the audiogram. It looks like a notch. There's a piece missing where that frequency was. So yes, beware of noise-induced hearing loss. Okay, let's go back to sensorineural. Okay, and then presbycusis. This is basically deterioration in hearing due to old age. So presby refers to old age. So it is lack of hearing through just aging, the aging process. So, you know, we talked about those little cilia, just, you know, with time, they just don't respond as much. And we also, I mentioned the high frequency sounds, which are at the top end of the cochlea. Those are the ones that are going to get more action. And so we tend to lose that hearing first. So in older people, this is the biggest source of sensorineural hearing loss. That's why old people have their TVs up so loudly. And the problem is, even when they put their TV up loudly, they still can't always hear, because remember how I said, just increasing the volume doesn't always help with the clarity of the signal. So it might be loud enough, but they still can't quite figure out what somebody is saying. Okay, I hope we're doing okay. So degrees of hearing loss. Now, we can talk about hearing, and we basically kind of separate it up into hard of hearing and deaf. I'm not going to go all through these numbers, but you can take a look at these. Know that, you know, we talk about hearing loss as being typically slight, mild, moderate, moderately severe, as being hard of hearing. And then deaf, we talk about as being a severe hearing loss or a profound hearing loss. And we've got the decibel levels next to it. Think about what that means. There is a difference, right, between being hard of hearing and either having some type of amplification and being deaf. And because deaf also means that you may be part of a deaf community, which is different from a hearing community. I don't know. I'm going to stop my share so I can see you all again. Oh, what is a documentary on Netflix that is set in the university that is a deaf university?
It's called Deaf U.
Deaf U. Yes.
Yeah.
Have you watched it, Cassandra?
I loved it. Yeah.
Isn't it interesting? And the hierarchy of kind of deafness and signing, and whether you have a cochlear implant or you don't. Yes, thank you. What's the university?
Gosh, my ASL instructor is going to hate me for not knowing this.
I won't tell him.
Gallaudet University. Is it Gallaudet?
Gallaudet, yeah, Gallaudet. Thank you.
Yes, thank you. If you haven't watched it and you do have access to Netflix, it's pretty interesting to watch. Because it is a university for students who are deaf, and it is just very interesting how, you know, the dynamics. Of course, there's lots of raunchy stuff going on as well. So that part, I don't know, you can just enjoy if you like. But I was trying to just really figure out, you know, what it's like for students who are hard of hearing versus deaf. Anyway, so that's worth looking into. That could be your winter viewing. Feel like you're doing a bit of work, but not too much. So there's that difference in between hard of hearing and deaf, and knowing that, yes, deaf often is spelled, if we spell it with a capital D, it means that you are part of that deaf community. Now, what I do want to show, this is called the speech banana. Now, what is interesting here is plotted onto this is an audiogram, and we are looking across the top, we have got hertz, and down the side, we have got loudness measured in decibels. So basically, these are all the soft sounds, and these are the loud sounds further down. So it may be a little bit kind of backwards than we normally think about a graph. We normally think about things kind of getting bigger, going up. But think about, this is soft at the top, and this is loud at the bottom. Now, when we think about speech sounds, and you can see plotted here in the yellow are all the speech sounds. So down the side on the right, you'll see normal hearing in an adult, a mild hearing impairment, a moderate hearing impairment, and a severe hearing impairment. If you look, all of the speech sounds fall within, basically, if somebody had a mild or a moderate hearing impairment, they could be missing a whole bunch of speech sounds. So don't let that term like moderate hearing impairment or even the term a mild hearing impairment fool you into thinking that it's not much of a problem. It can be. Look at that mild range. You would be missing all v. That's a lot of sounds. So when we're talking about children who've got a mild hearing impairment, that could be quite detrimental to learning speech sounds. So you just get an idea of basically, oh, here it tells you minimum level for hearing protection. So when you just mentioned, working at an airport, musicians, people in construction, oh, maybe people who work in landscaping, right? That would also be another way to lose your hearing as well. What I will just also bring up to you, perhaps, just kind of going back to this, when we talk about these hearing levels and we say somebody has a mild hearing impairment, and so that means 26 to 40 decibels, what does that really mean? What it means is that the way that we get somebody's threshold for hearing, maybe I'm getting ahead of myself. Let me just zip myself up and get there in a moment, because let's talk briefly about hearing screenings and hearing evaluations. So audiometry is basically how we measure hearing and hearing loss. We can do screenings, we can do pure tone hearing testing, and we can do speech audiometry. So a screening is where we basically screen 3 frequencies. Now remember, frequencies refer to pitch. And we screen 3 pitches, 1000, 2000, 4000 hertz. Those are frequencies that are very important for speech sounds. So we get a child, all children have this hearing screening, and we play them these 3 frequencies. And basically what we're looking for is them to be able to say, I hear it. So we play it at 20 decibels, which they should be able to hear. So if the child does not respond, so we play those 3 frequencies and we try both ears and the child doesn't respond, the first thing we do is we redo it. We re-instruct them. We tell them, you've got to raise your hand when you hear that sound. We make sure that our equipment is working right as well. So we redo it. If they pass that rescreening, then the chances are their hearing is pretty good. If they fail that rescreening, then we are going to send them for an evaluation. Remember, a screening is just to assess the likelihood that this person has a hearing impairment. Now, obviously, if they pass it first time, then they passed it. That's fine. So it's really, we talked before about speech sound screening. We want to check, who's at risk of not having all their speech sounds, who's at risk of having a hearing impairment. So we do these screenings often in preschool and kindergarten or at your doctor's office. So let's talk about the pure tone hearing test. I'm only going to go through it fairly quickly because I do want to recognize that we've got just under 10 minutes left, and I want to make sure I get through a little bit more of the material. Is that basically, if you've ever had a hearing test, it's you hear these pure tones or these beeps. Now, this is where I got ahead of myself. The threshold is the quietest level at which you can hear the beep 50% of the time. So remember, you're sitting there, you've got your headphones on, and the person says to you, okay, you're going to hear these beeps, raise your hand when you hear the beep. And remember, when we talked about amplitude, we're measuring in decibels, right? So we hear the sound and we raise our hand. Now, the threshold is the point at which you hear that sound 50% of the time. So I would think about it as it's the point at which you go from not hearing it to hearing it. And if you've ever done a hearing test, you'll know exactly what I mean, because it's where you sit there and you go, I think I heard a beep. And it's that point, it's where you just hear it. So when we're talking about threshold, remember, we're not talking about somebody can hear that sound really clearly. We're talking about the point at which you just are able to hear it. So why do we care about this? Let's go back to that speech banana. You know where we've just said a mild impairment is in this range. So think about this, could be really devastating for hearing speech, because remember, the threshold is the point at which you just hear that sound. So somebody can only be just hearing those sounds. Well, that's not good if you're trying to hear speech sounds in a classroom, is it? So to do this, we put headphones on and we present these sounds at different frequencies. and we basically go to that lowest level at which the person, 50% of the time says, I hear that sound. When we put the headphones on, conceptually, here's the part I want you to get. When you put those headphones on, you are testing the whole of the ear. You're testing the outer ear, the middle ear, and the inner ear, right? Because you play a sound from the outside, it has to get all the way in up through the auditory nerve until your brain processes it and says, I hear a sound. So if somebody has a problem, we put those headphones on and they don't raise their hand, we know that they have a hearing problem. Do we know where the hearing problem is? Nope, because we've just tested all of it. So they could have a conductive hearing loss, they could have a sensory neural hearing loss, they could have a mixed hearing loss. So think about, that's only testing everything. It tells us there is a hearing loss, but it doesn't tell us where it is. So what we have to do is do something called bone conduction. And bone conduction is where we put a little bone oscillator, we put it onto the head, and it speaks straight to the inner ear. Because then I can now test the inner ear and I can see if the inner ear is working. If the inner ear is working, and I put that bone oscillator on and I present those sounds and the person waves their hand around, yep, I can hear it, I can hear it. Oh, well, that tells me the inner ear is working. The problem is the outer or the middle ear. So we use that bone conduction to be able to isolate the inner ear. I think that's all I'm going to say about the pure tone testing. Here are the pitches that we test. We test all the pitches basically related to speech. Maybe the last thing that I will talk about is briefly masking. So masking is, you can imagine, if I'm testing your right ear, now remember, your bone, your skull conducts sound as well, right? Because it's when you hear sound on one side, it gets conducted to the other side. So how do I know then that I'm really testing one ear? Well, we actually put noise into the ear that is not being tested. So if I'm testing the right ear, I may have noise going on in the left ear because I've got to keep that left ear busy so that it doesn't respond by mistake to the sound that I'm testing in the right ear. So just know that that masking noise, it's often like a white noise, like shh. It goes into the non-test ear to keep it occupied. Now, I think, to be honest, I think what I'm going to do, I am not going to expect you to understand an audiogram. So we can skip all of this. Don't worry about the audiograms. I will not put it on the test, and I will take it out of the running. I think it's just too much for us to do. So you can ignore the audiograms. Okay, so that's what we've got left. Okay, so just in the few minutes that we have left, so we can ignore all of that stuff. I'm going to give you your preview of what you're going to be looking at for the rest of the week. You are going to be taking a look at how we test hearing in young children. Because obviously if we've got little children, they can't respond accurately and, say that they've heard a sound or not. So you are going to be looking at how we test young infants, babies, how we test older infants like toddlers, and then how we test young children. These are populations that really cannot respond to a beep and waving their hands. You are also going to be looking a little bit about oral rehabilitation and habilitation. So what do we do with somebody who's got a hearing loss? You are going to be looking at this. So I'm going to put all of this into your weekly look later on this afternoon. And then you're just going to take a little look at some amplification and how we improve somebody's hearing. So that's the part that you've got left to do, hopefully not too much. So just once again, don't worry about the audiograms. I think it's just too much to try and cram in. And you will learn all about that in another class, in an audiology class. But I would like you to just get a little idea of the testing and then the amplification. Woof. That was just get through all of that, wasn't it? So that's it. Questions, thoughts about audiology and hearing loss? Please remember as well that if you have questions, I will open up a little discussion board for us as well. And the muddiest point that you have, actually, let's just keep maybe the muddiest point. The muddiest point, remember, that's a little discussion forum on Canvas. If over the next week you think, God, what did she say about that? Or I'm not sure how to do that. Then please, write a question in the muddiest point and try and keep an eye on it. And if you can help somebody else out, great. If you don't get any response, I will try and keep looking at that as well. But I must admit, sometimes I'm not so hot on that. So you can always email me as well. And come to office hours. I think that's all I have to say, other than thank you for making it through a rough, tough semester. If you've made it through, well done. You should feel really good about it. If you've had a rough time, try and be kind to yourself. Recognize if you took too many classes this semester, that happens as well, especially, the full semester. If you're new to Cal State LA, you may not be prepared for the jump from a junior college or a community college to a Cal State, and find that you took on more than you could manage. I think often we feel pressured either by, other people, by ourselves, to say, I got to get through college and I got to get through it fast. And sometimes the reality is we're trying financially to get through college quickly, but you don't do yourself any favors in the long term if you take on too much. So if you've taken 5 classes, it's probably too much. If you've taken 5 classes and you're working, definitely too much. So don't be hard on yourself if you didn't do as well as you wanted to when you had a lot on your plate, and see if there's a way that you can really manage upcoming semesters to say, there's only so many classes I can take at one time if I want to do well. If you just got to get through college, that's another story. Sometimes we just have to get through something. But if you're thinking about this as your major and you want to get good grades in this, in all of your ComD classes, you may have to take fewer classes and take a little bit longer. Being a little bit older, what I can let you know is that in the big picture, taking another semester, another year, another 2 years to get through college, in the big picture doesn't really make a big difference. I know financially, again, it can take a hit. I got to tell you, I'm still paying off, my husband and I are still paying off his student loans. I mean, they just follow you along and you just have to say, I'm going to have student loans. But just do the best that you can, and, try and reach out for help if you need it. Otherwise, thank you very much. If you haven't already filled out, I think student surveys are up and about. Normally, if we were in class time, I would have you fill those out in class. But if you can fill those out, we take our feedback very seriously. It helps us figure out how we can, I think, really be better teachers for you. But thank you, everybody. And I would say goodbye.
Bye. Thank you so much.
Unmute and goodbye. I'll stop the recording so that you can, if you want to say anything